Okay, so now let's continue with the comparison between DI and SIAD. So in your handout, I discussed them separately. In our video discussion for today, I will have here a summary of their comparison so that we can easily see their differences. So we have here first in DI or diabetes insipidus. This is characterized by hyposecretion of antidiuretic hormone or your arginine vasopressin. While in your syndrome of inappropriate antidiuretic hormone, what happens is that there is hypersecretion of antidiuretic hormone. Let's now go to their respective causes. For DI, we have here our mnemonic. Ayan. So that is easier for you to understand. First one is inflammation or infection. Of what? We have here infection or inflammation of the meninges, also known as your meningitis. We also have here encephalitis affecting the brain. We also have here tuberculosis. So these are the different disorders or diseases that could now lead to DI. What else? We also have another one, which is your T, tumors of the brain. We also have lymphomas. And we also have breast and lung cancer or lung tumors. Another would be your conditions that will now increase intracranial pressure or pressure inside your skull. So that is affecting already the brain. Examples of these conditions are trauma or motor vehicular accidents that will now lead to trauma to the brain or injury to the brain. We also have other disorders such as tumors or cancerous cells growing inside the brain. And we also have another here, mnemonic trauma. Trauma, again, motor vehicle accidents, or we also have here any concussion, contusions in the brain. We also have the last one would be surgery of the posterior pituitary gland. Again, I discussed already that the posterior pituitary gland is the one responsible in releasing ADH into the bloodstream. Now let's go to your SIAD. Causes naman ng SIADH, we have here the most common one is bronchogenic CA or bronchogenic cancers. So in this case, there is already or it is mainly related to lung cancer. Bakit kaya anong relationship ng lung cancer or lung CA with SIAD? The malignant lung cells in lung cancer have the tendency to synthesize or make as well as release antidiuretic hormone in the body. So yun yung nangyayari in lung cancer. The malignant or yung cancerous lung cells will eventually synthesize and release ADH, therefore increasing secretion of vasopressin or antidiuretic hormone, which will eventually lead to SIADH or SIAD. What else are the other causes for this disease? We have oat cell carcinoma, and we also have here tumors or trauma in the central nervous system. We may also include here infections of the central nervous system, therefore affecting the brain as well as the spinal cord. So those are the different causes for both disorders or diseases. Let's now proceed with our clinical manifestations or signs and symptoms. I arranged them in a way so that we can see yung opposites nila. So we have here in DI, we have severe polyuria or excessive urination. What do we mean by this one? Or ano yung parameters natin for severe polyuria? The patient will usually excrete or they will now start urinating more than 4 liters of urine per day. Imagine that, more than 4 liters per day. Or if the patient will now start, upon assessing the input and output of your patient, you would notice that the patient will now start excreting or urinating more than 250 ml of urine every 2 hours. So pag more than 250 ml yan, automatic ay baka polyuria. This may be due to diabetes insipidus. What else? You have to remember that ang usual na urine output natin, ang normal is 30 ml per hour. In ADH In SIADH naman, ang problema natin is again retention of fluid in the body. Therefore, low urine output. Dahil mababa ang urine output natin, ano yung itsura na ng urine ng pasyente? Very concentrated. So, ang kulay is around yellow and even orange sometimes. So, that is for SIADH. What about specific gravity of the urine? What do we mean by specific gravity in the first place? Urine specific gravity will now refer to, or wag muna natin isama yung urine. What is specific gravity? This is simply a term we use in order to measure yung concentration ng solution. So in this case, ang tinatanong natin would now be, or what we are trying to determine is the concentration of urine. By concentration, we are trying to look into the amount of solute in the solution compared to the amount of solvent. The solvent in urine would now refer to the water. The solute in the urine would now refer to any byproducts of the urine such as urea, what else? Sodium as well. We also have potassium din, pwede yan. So those are the different solutes found in the urine. In this case, since ang hinahanap natin is concentration, we can therefore conclude that if there is high urine-specific gravity or pag mataas ang urine-specific gravity natin, ibig sabihin, mas madami ba ang solute kaysa dun sa tubig? Or mas mababa ang solute kaysa sa tubig? It is mataas. So, ibig sabihin, if there is high urine-specific gravity, there is concentrated or there is too much solutes found in the solvent, which is water in the urine. So, in this case, ano ba yung kaninong disorder ba yan? Kanino natin mai-attribute ang concentrated na urine? It is under SIADH. So dito, high urine-specific gravity. Dito naman is low urine-specific gravity. So what are our parameters or numbers for this one? The normal urine-specific gravity of our urine, that should be around 1.005 to 1.030. So, yan yung normal na urine-specific gravity. So, ibig sabihin, kung mababa ang urine-specific gravity, that should be less than 1.005. Pag dito naman, mataas ang urine-specific gravity, the value is more than 1.030. So that is how we're going to compare both. Kasi ang range natin, normal, is 1.005 to 1.030. Now, let's proceed to the next one. Another parameter would be osmolality. Again, just like your specific gravity, osmolality would also look into the concentration of a certain solution. So, concentration rin yan. Parang specific gravity rin. Yun nga lang ang measurement natin or ang unit of measurement natin sa osmolality kasi is milliosmoles per, that is, I think that's liter. Yes, that is milliosmoles per liter. Again, yung dinidetermine yan is concentration. So, osmolality can refer to urine osmolality or serum or yung blood. Serum osmolality. So, either urine or serum. In our illustration here, we're talking about serum. So, ibig sabihin blood. Take note that if there is high serum osmolality in the body, magkakaroon ng low urine osmolality yan. In the case of SIADH or DI, so if ever mataas ang serum osmolality ng katawan natin, dun sa urine osmolality niya, opposite. So, mababa. Kaya, we can also deduct that if serum osmolality is low in the body, urine osmolality is high. It's because, again, remember, the kidneys will now regulate the amount of solute as well as solvent or water. It will regulate water in our body. So, ibig sabihin, pag masyadong madaming nirelease ang urine, pag masyadong maraming nirelease ang kidneys na urine, ibig sabihin, mas concentrated na yung solution dun sa katawan natin. Tapos mas lusaw, di ba? Mas nalusaw jay urine ti pasyente tayo. So that is, so if ever magre-reabsorb naman yung kidneys natin, mababaliktad yan. Kaya dapat inverse relationship yan. Ayan, again, I mentioned to you, the one we're talking here in our osmolality, dun sa table natin is serum or yung sa blood. In DI, hyperosmolality. Bakit hyperosmolality? Again, since ihi ng ihi ang pasyente, there is lack of water inside the body. So, ibig sabihin, there is too much solute content in our body compared to the amount of water. What are the solute contents of our body? We have here blood products, RBCs, white blood cells, platelets. We have even the electrolytes. So, sobrang dami nila compared to the amount of water in our body because ihi nga ng ihi yung pasyente. Nawawala yung tubig. That is why it's hyperosmolality. Again, I mentioned to you inverse relationship ng serum osmolality and urine osmolality. Because mataas ang serum osmolality, ang urine osmolality naman is mababa. And then we're just going to do the opposite for SIAD. So since mababa ang serum osmolality in SIAD, it's because of hemodilution. Sobrang daming tubig dun sa katawan compared dun sa ihi ng pasyente. That is why nadadilute yung blood products natin. Since there is decreased serum osmolality, ang urine osmolality naman natin for patients with SIAD is high. Kasi nga, wala nang masyadong tubig dun sa ihi. Sobrang concentrated na yung ihi. Okay. So those are that is now the discussion on osmolality. What is the normal value for our osmolality? In serum osmolality, the normal value is 275 to 295 milliosmoles per liter. So, ibig sabihin, pag DI yan, ang magiging value is less than 275. Doon naman sa SIAD natin, the value is more than 295 milliosmoles per liter. Okay, now let's go to serum sodium levels in the body. By serum sodium, we mean sodium in the blood. In the case of DI, hypernatremia, we mentioned there is overconcentration of solutes in our blood because of the loss of too much water in the body. Kaya nagkakaroon ng hypernatremia. While in SIAD, again, the opposite, hyponatremia. Bakit kaya mababa yung serum sodium ng katawan natin in SIAD? It's again because of hemodilution. So, sobrang dami ng tubig sa katawan natin. Parang na-over-dilute na yung sodium natin. So, in this case, parang magkakahiwalay-hiwalay yung sodium natin and even other blood products in our body. The problem with this one will now be seizures. Pwedeng mag-seizure ang pasyente, pwedeng makoma yung pasyente. That is why in hyponatremia, one thing you need to watch out for is headache. Headache is an early sign of hyponatremia. Take note, pag may headache, there's a possibility may hyponatremia which could lead to seizures. Ayan. Ang sodium kasi very important in conduction of, it is also one of the important electrolytes in our body for conduction of our impulses. Hyponatremia. So what is the normal serum sodium levels in our body? Normal serum sodium levels in our body is 135 to 145 mEq per liter or milliequivalents per liter. So, ibig sabihin, again, since dito, hypernatremia, ang amount of serum sodium is more than, anong parameter natin? Max 145. Dito naman sa kabila, in SIAD, since there is hyponatremia, less than yung normal range, which is less than 135. Ayan. Okay, let's continue. Because of polyuria in DI or daming ihi, diabetes insipidus, you will now have to watch out for hypovolemic shock. due to the lack of water in the body. So, hypovolemic shock. Wala nang masyadong ma-circulate or wala nang maipump ang heart natin na tubig. It's because sobrang konti lang. Hindi na aabot dun sa buong katawan natin yung tubig. Kasi nga kulang. Okay. What about in the case of SIAD? The problem here is hyponatremia. Very important. Seizures. Again, early signs, you have to check kung may headache ang pasyente or there is already mental status changes. So in this case, you have to check for confusion, lethargy, the level of consciousness of our patients, and the neurologic status of our patients. Okay? What else? Hypotension in the case of DI, kasi nga konti na ang tubig, konti na ang blood volume in the body, wala na masyadong maipapump dun sa katawan. What about in patients with SIAD, that is severe hypertension? Why? Because there is already retention of fluid in the body. Because of the retention of fluid in the body, sobrang dami na, sobrang na-overstretch na yung blood vessels natin due to the amount or excessive amount of fluid. Weight loss is usually seen in DI, again because the patient keeps on urinating. While in our patients with SIAD, that is abnormal weight gain due to retention of fluids. Abnormal weight gain, you would notice the patient would now have edema. So, abnormal weight gain or hypervolemia. Hypovolemia naman dun sa DI natin, di ba? So, in this case, hypervolemia naman dun sa SIAD. So, what are signs of hypervolemia? We have weight gain, edema. We also have here shortness of breath. Kasi yung tubig, it now starts diffusing into the alveoli of your lungs, kaya nahihirapan silang huminga. We also have here hypertension, of course, because of the increased blood volume in the blood. We also have here other clinical manifestations, muscle pain and weakness for patients with DI. And we also have dehydration. Severe dehydration, you have to take note. Kung merong postural hypotension, we mentioned that if the patient starts to sit down or suddenly stand up from a lying position, usually they become easily, or they will now experience dizziness. Ayan, dizziness yung tamang word. Pag postural hypotension, that is when they change positions, nagkakaroon ng dizziness in our patients. What else? Tachycardia is another sign of dehydration. What else? Of course, dry mucous membranes. You have to check that. Yung skin, yung texture ng skin natin, if it is dry or if it is moist. Ayan. What else? For your SIAD naman, anorexia or the loss of appetite. And we also have nausea and vomiting. Okay. Now, let's continue. Diagnostic tests naman. In diagnostic tests, very important urinalysis for both. You would also notice in SIAD, yung CBC ng pasyente natin, merong hemodilution. So, we have hemodilution. We also have here monitoring the electrolytes of our patients, especially serum sodium. Dito, hyponatremia. Sabi natin, very important to check that one, especially headache. Because this is a sign of hyponatremia, early sign of hyponatremia, para bago pa man magkaroon ng seizure dun sa pasyente, at least we can easily correct it already. A very important test we need to know is your water deprivation test. In water deprivation test, what do we usually do here? In water deprivation test, anong nangyayari? We will now withhold water. We will not let our patient drink water or fluids for 8 to 12 hours. Or until yung body weight ng pasyente natin, the patient will start losing around 3 to 5% of his body weight. So it's either we're going to withhold fluids for 8 to 12 hours or until 3 to 5% of his body weight is lost. After that, we're going to we're going to test the urine-specific gravity. As again, we mentioned, urine-specific gravity, ang normal sana 1.005 to 1.030. Pero, pag yung urine-specific gravity ng pasyente natin is less than 1.005 or mahirap umakyat, yung levels ng specific gravity ng urine ng pasyente, ibig sabihin the patient has diabetes insipidus. Okay, now let's go to the last one, management or nursing interventions. So we have here for diabetes insipidus, adequate fluid replacement because of dehydration. In SIAD naman, sobrang dami na ng fluid sa katawan. So we have to restrict fluids that is around 500 ml per day, di ba? What else? In this case, strict monitoring tayo ng INO, especially in SIAD. Kaya dapat very careful tayo dun sa IV administration. Dapat stricto kayo dyan drops per minute you. It's because kahit konti lang na increase, this can lead to already hyponatremia causing headache and eventually seizures. What else? Dun sa monitoring natin, halos the same naman. Vital signs, neuro, daily weight of our patients to monitor yung amount of fluid that is retained in our body. Input and output, specific gravity. Okay, now let's go to the actual management. In diabetes insipidus, we give them, since kulang tayo ng ADH, magbibigay tayo ng synthetic ADH or synthetic vasopressin known as your desmopressin. Yung desmopressin na yan, or your DDAVP, it is a synthetic vasopressin that will now mimic or parang tinutulad niya yung epekto ng antidiuretic hormone. Pero, in your desmopressin, it does not follow or it does not mimic yung vascular effects ng ADH. Ang effect niya lang is that it's going to affect how the kidneys will now reabsorb yung fluids in our body. Ayan. In your DDAVP, the mode of administration would now be intranasal. So, parang spray siya. You're going to apply spray in the nasal cavity of your patient. That is done 1 to 2 times every 12 to 24 hours. Okay, so that is for the desmopressin. What about for medications naman ng SIAD? In SIAD, we usually give them salt. Kasi nga, may hyponatremia. Kung hindi man salt, pwede rin natin ibigay ang high sodium content na saline solution. So we have 3% saline. That is a hypertonic, that is already a hypertonic solution in our patients. What else? We also give diuretics for patients with SIAD. Why? Because, again, nare-retain yung fluid sa katawan, increased or nagkakaroon ng hypervolemia, and we do not want that. That is why we give them diuretics for them to urinate. Diuretics may be in the form of loop diuretics or your furosemide. Pero ang problema kasi sa furosemide, what happens in here, you start losing a lot of potassium. You may also lose, of course, you will lose a lot of sodium. Kaya kailangan talaga natin ng replacement of salts. What else? They may also give them potassium-sparing diuretics. From the word potassium-sparing diuretics. Examples of this one. Ito, furosemide. Naku. Furosemide, yung loop diuretic. Yan, that is a name of a drug. Pag naman potassium-sparing na diuretic natin, in the case of potassium-sparing diuretic, furosemide, loop diuretic. Pag potassium-sparing, we have here your spironolactone. Spiro dapat, hindi spino. Spironolactone. Potassium-sparing diuretic, if ever, for example, mababa yung potassium levels ng katawan, ito yung binibigay na diuretic para hindi ilabas ng katawan natin yung potassium. Demeclocycline. In demeclocycline naman, it inhibits the action of your ADH. It inhibits the action of your ADH in the kidneys. So, ibig sabihin, maglalasan yung reabsorption ng kidneys natin if we give them demeclocycline. Okay. Ayan, other interventions provide safe environment for our patients. For our patients with DI naman, monitor for hypovolemic shock. Hypovolemic shock. Again, what are early signs of shock again? Hypotachy-tachy. Yan. Gasgas na masyado to, no? Hypotachy-tachy, hypotension, tachycardia, tachypnea. And give them medic alert bracelet. This is to notify other healthcare professionals who will take care of them that the patient already has diabetes insipidus. They have to watch out for hypovolemic shock. So those are the things we have to remember with our diabetes insipidus and SIAD.